how to propagate it, along with Dr. Mahesh and Dr. Divya. So without wasting time, I'll just start the session with Dr. Divya Alex. She is consultant in Ahilya Hospital, veterinary consultant, and will be talking on pathogenesis and classification of ROP. Over to you, Dr. Divya.
A warm good morning, everyone. I thank Dr. Anubosa and KSOS for giving me this excellent opportunity. So the born too soon babies or the early fighters, why is this subset of population so significant? Because preterm birth is the leading cause of neonatal mortality, and from an ophthalmic point of view, unfortunately, retinopathy of prematurity is the leading cause of preventable blindness in infants. It is preventable. That means if we act on time, we can save the vision. And our country, India, leads the top with 3.5 million preterm births. And this accounts for 26% of the neonatal death in the world, according to the UNICEF. So this resulted in strong political commitment, and India came with a new action plan, that is the India Newborn Action Plan. It aimed to end the preventable newborn blindness, deaths and stillbirths by 2030. A lot of newborn care NICUs were set up at the district level, but this was a double-edged success story. Since the launch of INAP in September 2014, the country has achieved remarkable progress in reducing newborn and infant mortality. In fact, from the 2014 to 2021, there was a 27% reduction in the neonatal mortality rate. But there was an unintended consequence. The babies who previously would not have survived started to survive. And these the same infants were exposed or supposed to have exposed to supplemental oxygen therapy and prolonged intensive care. So this increased the ROP risk pool. And when the NICUs expanded rapidly, there was definitely a gap in the specialized ophthalmic care for ROP screening. So there was an increased incidence of the ROP owing to the wide variation in the neonatal care, and it is even found that more mature and heavier babies started developing ROP. So for this, we have to understand the normal retinal development. So in utero, there is a perfect environment for vasculogenesis. Vasculogenesis is the de novo formation of the primitive vascular network. And in utero, the metabolic demand always exceeds the oxygen supply, as there is always a physiological hypoxia that is maintained. And this physiological hypoxia will induce certain growth factors such as VEGF, the IGF, the hypoxic induced growth factor. This all causes angiogenesis. Angiogenesis, it is the growth of new capillaries from the pre-existing blood vessel. And this blood vessel will grow to the nasal ora serrata in 32 weeks and the temporal ora serrata by 40 weeks. But what happens in the preterm babies? So in the preterm babies, there is no longer the ambient uterine environment. So even the atmospheric oxygen will be a bit high for them. Then this period, the babies will be starting some respiratory distress. We will be pumping the babies with oxygen. So this oxygen, so instead of the physiological hypoxia what we need, there will be a pathological hyperoxia. So in response to that hyperoxia, the first response in utero will be the severe vasoconstriction. So in this vasoconstriction, there will be abrupt stoppage of the retinal vasculature. That means the retina is always sending a false alarm that we don't need oxygen anymore. So there will be abrupt stoppage of the growing vasculature. This is the phase 1. And after that, along the time, the babies will be showing some amount of improvement. The baby will stabilize. Then you pull off the ventilation and give room air or blended air. There will be a lot of oxygen fluctuation that is happening. And this stress will lead to oxygen reactive species, releasing lot of VEGF, hypoxic induced growth factor. But this time the VEGF is going to come back more than that of 100 times what was in utero. So this leads to the phase 2, that is the vasoproliferation. So there is a phase 1 when there is a VEGF downregulation and abrupt stoppage of retinal vasculature, and this is the phase 2, there is an upregulation of VEGF which is causing vasoproliferation. So you have to understand that ROP is a time-bound disease. It won't be present at birth, and between the phase 1 and phase 2 it takes 3 to 4 weeks. That is why we are keeping an ROP screening at 30 days of birth. So how exactly it progresses? There is a vascular retina and there is an avascular retina. So when there is a demarcation line happening between these two, vascular and avascular, we call it as stage 1. And when this line gets a height and width, that is called as a ridge, that is the stage 2. And when there is an extravascular proliferation into the vitreous or flat NV, stage 3, partial retinal detachment, stage 4, and when there is a complete retinal detachment, you call it as stage 5. So you trace the retinal vessels and you can see the abrupt ending of the retinal vasculature. After that, it is a translucent zone. This zone, you call it as incomplete vascularization. There is no ROP, just that the vascularization is not complete. So this is your stage 1 of the demarcation line, stage 2 of the ridge, and stage 3 with the extraretinal neovascularization, stage 4A, the partial detachment, 4B, if the partial detachment is involving the fovea. And stage 5A, it is the open funnel where you can see the optic nerve head. Stage 5B, it is the closed funnel. And 5C, it is the closed funnel which is associated with anterior chamber findings such as AC shallowing, rubeosis, or iridocapsular adhesions. And first developed in 1984 and revisited in 2005, the ICROP has come with the 3rd edition. And why? Because the understanding of the ROP has changed. That is, now it is considered to be a worldwide problem. So what the low-income countries ROP might be having different pathologies from the standard literature. And obviously there are innovations in the ophthalmic imaging, and anti-VEGF treatment is also new. So this is the zone 1, that is the circle right at the center, the radius of which is that twice the distance between the center of the optic disc and center of the macula. And zone 2, from the periphery till the nasal ora serrata, this circle, and whatever the temporal crescent is remaining, this is the zone 3. So ICROP has come with a newer term, that is the posterior zone 2, that is 2 disc diopter from peripheral to the zone 1. So whatever disease in the zone 2 may behave more like zone 1, this posterior zone 2 should be considered as worrisome. And next terminology that has been introduced by ICROP is the notch, that is the incursion of this ROP lesion by 1 to 2 clock hours into a posterior zone. So earlier you would have called it as a zone 1 disease, but now it is zone 1 secondary to the notch. And defined in 1985, the plus disease was considered to be something that is vascular dilatation and tortuosity. Lot of confusions were there, but now it is considered as any abnormal looking vasculature in the zone 1, and this should be considered as a continuum, that is a progression of the disease. And the aggressive retinopathy of prematurity, now this is the term instead of APROP, and the hallmark of aggressive ROP is the rapid development of pathologic neovascularization and severe plus. And more than the location of the disease, the important features are the tempo and the appearance of vascular abnormalities. So there will be vascular looping with severe plus, and there is an ill-defined junction usually between the vascular and avascular retina, which we call as the deceptive featureless junction. And this is mostly considered to be an oxygen-induced retinopathy. So screening will be dealt beautifully by Anubhav sir, but always remember the code of 1, 2, 3, 4. And to conclude, ROP is a time-bound dynamic disease, and we have got only a small window of opportunity for effective management. And as our country tops the number of preterm birth, there should be increased awareness of ROP, and remember that every single blind kid will be a tragedy. So thank you, sir.
Thank you, Divya, for a very elaborative explanation of pathogenesis, which is very important. So, anything to ask, ma'am? Because yes, she has given very detailed explanation. A discussion we'll take in the end. So I'll just start with the second talk by me on screening and treatment.
So now we welcome Dr. Anubhav Goyal for the second talk, screening and treatment in retinopathy of prematurity. He is a very passionate person about ROP. So Anubhav, please.
Slides, please. So good morning, everyone, and thank you, KSOS, for giving this opportunity. Mine is on screening and treatment in ROP. So as we all know, it's a vasoproliferative disorder of retina in premature infants. And if you see, 1 out of 820 babies are getting blind due to ROP. Even a single child getting blind is a lifelong pain for not only for child, but for parents and whole community. So timely screening and timely treatment is at most necessary. So screening, because screening can prevent this disease to get the eyes blind. And it has a lot of medical legal implications. As you can see, there are a lot of compensation has been honored by a court of law for failing ROP or missing ROP, which can be till 3 crores in India, which has been already done. So for Indian screen guidelines, as Dr. Divya has told, it is 1, 2, 3, 4 rule. It's a golden rule. Screen before 1 month of premature birth, screen less than 2,000 grams of the baby, and below 34 weeks of gestation, which is very necessary. Earlier risk babies, you can screen a little bit earlier, like 2 weeks after the birth. So golden rule is 1, 2, 3, 4. We need an indirect and 28D or 20D lens, dilating ROP drops, paracane, and vector and speculum to screen the babies. And preferably, I prefer to screen in the NICUs under the care of neonatologists and the nursing staff who are well trained. You can all discharge and stable babies, you can screen in OPD, but most of the babies are usually sick and needs ventilator. So better to screen in most of the sick babies in ICU itself. How to make ROP drops? So ROP drops is exactly the half concentration of normal adult T plus drops. So if you dilute it with normal saline or CMC in 1:1 ratio, it will be nearly ROP drops, and you can use it in, you need not a special ROP drops to use it. Baby should be nicely warmed, keep warm and mummified during this treatment, because babies are very vulnerable for hypothermia during that time. And eyes should be properly dilated for a proper screening. There are a lot of imaging things like RETCam, NEO, Optos, and smartphone imaging for ROP. These are comparative images of the smartphone, NEO, and Optos. Smartphone, yes, it has a limited field of view. And comparative image of 20D, 28D, and 40D by smartphone, Optos, and NEO. You can see the field of view. If you see, you can easily screen from disc to periphery by a NEO camera with a good field of view. Smartphone also can give you reasonably good images with limited field of view, but yes, you can screen nicely and counsel the parents. And the smartphone can also see very rare other diseases also in the neonates, which can be seen after the birth. So counseling parents and counseling neonatologists and keeping them in the loop, explaining them every time all the details clearly is very important. With imaging, it's the best. Because if they don't trust you, you will not going to succeed this preventable blindness. Always use some proper documentation forms for documentation, and you can also obviously follow up these things. So next is treatment. Treatment consists of, way back in 1980, it was ROP, which showed the importance of cryotherapy. Then in 2000, ETROP shows the importance of laser in ROP. And in 2010, then anti-VEGF came. It's a revolution of in ROP with this treatment, and shows the importance of bevacizumab. You can easily see the amount of unfavorable anatomical outcome has improved from cryo-ROP to beat ROP, and hardly any baby was left with unfavorable outcomes. It is this beat ROP which has shown that anti-VEGF is better for zone 1 and laser is better for zone 2 treatment. And ETROP gives actual treatment classification for ROP, whom to treat and whom to observe. So now anti-VEGF era is there. There are a lot of anti-VEGF which has been used in ROP, like bevacizumab, ranibizumab, and Eylea. A lot of publications are there on it. And if you see, our Anand sir has already published an article which has shown that a lot of studies, Asian population studies, shown that zone 1 ROP and AP ROP needs and works well with anti-VEGF rather than laser in zone 1. And for zone 2, both laser injection works same. But a combination of anti-VEGF and laser treatment for injection followed by laser is now the practice pattern in India for type 1 ROP and AP ROP and zone 1 ROP. So as recurrences of anti-VEGF is varying, and bevacizumab gives a very long window period for improvement in vascularization, and ranibizumab is much below than this. So ranibizumab shows recurrence after 7.7 weeks, and bevacizumab can take 12 or more weeks for recurrence. So it's the best drug, even now in ROP. A meta-analysis shows that laser shows least recurrences as compared to anti-VEGF. And but if you compare that, bevacizumab has the best result in recurrence. It delays our recurrence. Second comes aflibercept, and least is ranibizumab. Ranibizumab recurrence is much earlier. And beta ROP has already shown recurrence after bevacizumab will take more than 16 weeks. So it's a well-known thing. Anti-VEGF is good in refractive profile also because laser cause induced myopia, which is not seen with anti-VEGF. Anti-VEGF, what earlier understanding was, you give one anti-VEGF and if recurrence is there, give laser. But now the slowly understanding is changing, you can give more than one anti-VEGF. Search paper shows that you can give 2 doses as early as 4 weeks interval and can give maximum 3 injections in 6 months of treatment. And doctor says 67% of 8 doctors says in a survey that you can give both eyes injection at the same time, same day. So anti-VEGF, Avastin and bevacizumab, ranibizumab are the 2 preferred anti-VEGF in ROP. Bevacizumab shows it's a well taken treatment for treatment of ROP, but not approved. Even the vial shows it is not for intravitreal use. DGCI approved ranibizumab, both Excentrix and Resumab. Most of them are using Excentrix and Resumab, but yes, a lot of us are still using bevacizumab. So I prefer, for zone 1 ROP, I still prefer injection followed by rescue laser without waiting for recurrence. Once the zone 2 posterior vascularizes, I don't wait for especially AROP or half zone or zone 1 ROP. Surgical treatment, Dr. Divya Balakrishnan Madam will be covering for stage 4 and stage 5. So this is how the laser is given with this, without any skip areas with near confluent burns from the ridge till the far periphery. And this is how it's a case, another case example where zone 1 hybrid ROP was there with plus disease and ridge encroaching near the fovea and both the eyes, which initially treated with injection, ranibizumab, but recurrence happened after 3 to 4 weeks, for which laser was given. This is a very good thing, very good new update, which is called as peripheral avascular retina, which is has come up after the advent of anti-VEGF, which is very important to consider because if you leave 2 disc diameter of PAR, and if it is seen after 65 weeks of postmenstrual age, then it can cause a lot of retinal holes, retinal breaks, RD, and lattice degeneration, which can be a serious problem in later also. This is an example showing right eye. If you can see very clearly, there's 2 holes with a shallow SRF pocket in the avascular retina, which was seen in a 2-year baby, which we lasered, and the left eye was having a macular defect, which was also lasered. So timely treatment, even in patients seen PAR, is very important. Laser is given. This is how the laser and anti-VEGF injection is given in ROP. You can give in NICU. I prefer to give in NICU because most of the babies are very sick and very premature. So it's now unlike adult injections. You have to keep you have to use thinnest needle, take it vertically down, half length inside, just inject and come out. Don't try to see the needle inside. Should not direct towards the disc because the lens is bigger and you might damage the lens. That's all is needed. After injection, you might see clouding of cornea, which is a sign that something has gone in the vitreous cavity. So we are screening nearly 19 to 20 NICUs every week in Kachin and around with the initiative of CSR. We have a mobile van. We have screened nearly 16,000 babies since in last 10 years and lost 10 babies. Red eye reflex is a fallacy because by the time you lose the red eye, red reflex, baby is already blind with stage 5. So termination is on fully vascularized retina. We have trained a lot of fellows and still going on. This is a promotion education poster which we are giving. So the overall goal of ROP management is to prevent retinal detachment, reduce incidence of subsequent blindness, and promote optimized visual outcomes. Early screening and timely treatment is a goal for preventing ROP that we have to keep in mind. Thank you.
Thank you, Anubhav, for that wonderful talk on the screening and treatment. I think it is very important to remember that 1, 2, 3, 4, the golden rule, and which everybody should remember and follow. And so your preferred injection is bevacizumab?
I still prefer bevacizumab, especially for half zone or zone 1. We are taking it very carefully to NICUs and maintaining cold chain. I am still not using ranibizumab a lot.
Okay, Anand sir is also here. Sir, what does your take? So I think only thing that because the recurrence can be little late, so maybe that a longer need of follow-up should be there.
For especially half zone and zone 1, we will get a lot of window for the vessels to vascularize. Otherwise, if we have to laser just one zone 1 is vascularized, then it is again a trauma for the baby. A lot of area will get scarred.
Okay, thank you. So next.
Next, I will introduce Anand sir. Anand Vinegar sir is not only the torch bearer, but actually now a light-giving sun in ROP. He is the main person, not only in India and outside India also. It's an honor to have him in our session, coming from way long from Narayan Netralaya, Bangalore. He's a passionate and I have no words to say here for him. Sir, please, his talk is on how to propagate ROP awareness in your state.
Thank you, Anubhav, and thank you, KSOS. It's always a pleasure to come here into Kerala. Right, so I think Divya spoke about this. We are the highest number of preterms in the world, and there are a lot of reasons, and very importantly, I think the awareness in the neonatal community is very less. This is an impact paper that we put out about 10 years ago, and despite having wonderful care in healthcare, Kerala will still have a large number of babies who will turn blind if they are not screened on time, and I think this data is only increasing now because of improved neonatal care. So if you look at the incidence of ROP, earlier it was thought that it was going to happen only in urban areas, but our multicentric data in government rural areas has shown that it's almost comparable in the rural areas as well from Karnataka. A lot of my talk is based on this public health paper, which was published in the Lancet by 2 neonatologists, and that's from where we learn lessons from one of the most successful programs in the country, which is the polio eradication program. So steps on propagating it, I've been working closely with some other states, in fact with Kerala as well before COVID, where we had trained a few districts under the government. Something you need to have some sort of a leadership. So having a task force itself within the state, a core committee, or a Section 8 company, which is basically a not-for-profit company which can go out and look for funds. There are examples on how this can be done. There are charters with the National Task Force. We also have the Indian ROP Society, with both of them are members. And the best way to work to make it scalable is to work with the government, and that is with a public-private partnership. It's not simple. Every state has its own logistic issues, but that's the only way you can make an impact. For example, the special newborn care units, first thing you need to do is map out where they are, and that's relatively easy. The next thing is to map out where the ROP specialists are, and already if there are existing cameras. For example, there are already 7 existing cameras in the government setup already because they had purchased it in 2017 and 18. Here's a map of Uttar Pradesh. It's a very big state, 74 districts, 240 million population, but we're mapping it for them. They have a core committee. They're working on the lines of what I'm suggesting. And what you need to do is already map out who are the people who are doing the ROP screening, who are the ones who can do the treatment, and who are the ones who have the camera. After that, you can make a sort of a geographical model to see how they can move around within that geographical. Now, not all states are the same. You have hilly areas, you have flat areas. Kerala is longitudinally long. It's not very wide. And those are limitations that we have to understand when we make any geographical program. In Karnataka, for example, we have 6 teams that work through our 31 districts. So each team has roughly 5 districts. And we had started from 3 hospitals. We are now about 190. This is government and private. And all of these are covered by these 6 teams. So this is how you can maximize with just 6 cameras, 6 SUVs, and about 12 trained technicians. The next thing is you already have excellent people doing ROP, so you don't need to replace any of them with cameras. So you must have a 2-method model, either indirect ophthalmoscopy or imaging. So indirect ophthalmoscopy still has a lot of role, and I think except for the fact that there's medico-legal issues, which of course you can overcome, this is still one of the possibly the gold standards. And the only disadvantage is busy people like them who are also doing adult retina and not exclusively ROP are going to find it difficult to spread themselves thin. How many centers can you cover in a day, in a week, even if you are very good and passionate about it? So our model was, of course, to replace the so-called ROP specialist with non-physicians, trained technicians. So earlier we started with technicians, which is a vertical cadre. Then we started having optometrists, ophthalmic assistants, nurses. Then we started even training school dropouts. My point here is that anyone can be trained to do imaging because that works on pattern recognition. The next thing is to uniformize, homogenize the entire screening program. Now, a lot of you all will realize that even in Kerala, there'll be people who are treating differently. Not everyone's following all the guidelines at the same time. And that can become a problem when you transfer patients between yourselves, or for that matter, medico-legally. Now, if you are worried, if the government is worried that, oh my God, what is this camera coming? You need to come, you need to do indirect. Well, India has become the first country in the world to allow screening by non-doctors, and this is the national guidelines. This is not mine or yours. So they have to be convinced, also medico-legally. So this is what we did. We have started training a lot of people who are from different cadres, and we showed that these technicians can not only be trained to image these babies, but also to grade these babies. And how you levelize these, how do you say what is the skill of these technicians to take these images also has been published and has been, more importantly, this work has been incorporated in the government guidelines. So you have a level 1 technician who has certain amount of accuracy and we know his limitations. Then you have a level 2, a level 3 and so on. And what this model shows, and again been published, is that if you have this image-based model which goes around while you all are busy doing the treatment, then you will see no stage 5. That's what we saw. When we started off, there were 18 stage 5s within 3 months from the rural areas, and now for 8 years consecutively in India, in Karnataka, we have 0 stage 5s from any screened center, especially from the government cadre. The disadvantage was, of course, the cost of the camera, which is when we started working with Indian industry to make it cheaper. The next thing is you have to work with your stakeholders, and those are of course the neonatologists, but also the nursing associations, optometrists and parents. Here are some examples of what we are doing, not just in Karnataka, but through the Indian ROP Society. So conducting workshops, awarenesses, instruction courses, and then holding more closed door meetings with the actual stakeholders. So if it is nurses in a nursing college, optometrists in the Ophthalmic Council of India. Here's an example of what the Indian ROP Society is doing. Dr. Karobi is heading what's called the Ambassador Program, which is basically looking at optometrists and non-doctors, non-ophthalmologists, and we were trying to get a brand ambassador. You know, that's probably one of the reasons why polio worked, because they had Amitabh Bachchan's voice. Salman Khan became very close to becoming our ambassador, but did not. So we are still in the quest. I think having somebody like that, or maybe like a Deepika, will really help. But then also engaging the parents, and you all have an extremely educated force here. You know, yesterday in the cab driver driving me was telling me about the ISRO in Trivandrum, what all it has launched. This is unheard of in Karnataka. That's the level of knowledge your so-called normal laymen have, which means you need to cater to them. Now, when we started working with neonatologists, we were able to reduce the incidence of severe ROP from 80% to 30% in just 1 calendar year by allowing them to improve their own care. But this you have to do through the NNF. And then look at this captive audience. They are sitting there with their babies waiting to get dilated, and that's an excellent time. And we've been working with pediatrics department, with community department to improve breastfeeding, immunization, good neonatal care. All of this can be done while you are anyway screening. And counseling is so important, and this really helps if you are able to show them an image. Medical legal aspects. Convince your neonatology friends that they are responsible for any baby that within their care or within the care after they are discharged and they come back for immunization or whatever. The only time they may not be negligent is if they have documented that they have told them to come on time and they have not come on time. So contributory negligence, this is the case from there. And then of course uniform processes, whether it's the ICROP3, whether it's the national guidelines. Look at this. This is one of the court decisions which has used the operational guidelines in its judgment. So if you don't use the guidelines, the judges will. So this is something that you need to convince your neonatology friends. This is something that you will eventually need when you're making the entire program of the state under one admin level, which is why I thought you all should have a task force or through the KSOS. Why not? And right now you all have a president who's also an ROP person, right? So why not? So this is a dashboard for that example. This dashboard will connect all the cameras or all the work. It's like a registry but online where all the images sit in one. This we've worked with Forest to develop. It was particularly developed for UP. These are demo images, that's why we didn't put retinal images. So it was developed for Uttar Pradesh, 74 districts, bigger population, so it's pretty much. So the person who operates it puts the diagnosis. The person who is in charge of that zone will see the image with a notification. You will agree or disagree with your technician. That will go back to the technician. If you're on leave, the next person who is in part of that ecosystem will get the message, so on and so forth. And this has been validated by business schools across the country. This is some work that Kidrop has been doing now. We are now in 10 states, and we are mentoring them and financing them through NGOs like Have a Heart Foundation. And this is one of the papers that my colleague will be presenting at the World ROP next week, and how to make it sustainable financially. So if you have a hybrid model where you can continue to do free screening and free treatment for government babies, you can still be financially viable if you charge your private patients, and that works as early as 2 to 3 years. Within 3 years, you can break off from your funding and be completely financially viable. These are some new innovations. This is a camera that's just being launched. This is a Nubo camera by Remedio. You've probably heard of Remedio's fundus on phone and so on. So this is going to be probably, we hope, at least half or one-third the cost of the Neo camera. They have not yet come out with the pricing. It's 130 degrees. They claim that it works in small pupil as well. And of course, then artificial intelligence. So as more and more of you start doing imaging, we now have a completely Government of India funded, BIRAC department funded AI algorithm that we have developed, and it's going to be absolutely free for any government system to use because it's funded by the government. This is our first publication. And unlike any other AI system in the world, currently the Americans have an AI system where they only can tell the plus disease, plus yes or no, vascular severity yes or no. But the Indian algorithm will be the first one to decide, to tell you whether there is disease also and plus also, and therefore refer, and refer how? Urgently, follow up, or completely normal. And we absolutely invite everyone, all of you, to participate in this validation because it's our model, our country's model. And then, of course, some other innovation in terms of tear biomarkers, where we're taking the tears of these babies and we're able to predict which of these babies will eventually get disease. Unfortunately, it's currently at a lab model level. To make it scalable to the community, we'll need to work a little more. But these are some of the publications. And look at this, telemedicine model, ours at least, worked continuously every single day of the lockdown. So this is the power of being able to do it. I want to end with this financial impact that you can make. If you're talking to a politician, the ROP numbers may seem less than glaucoma, diabetes, or cataract for sure. But if you can tell them the impact it can make, this is the formula you need to use. Number of babies you've treated into the per capita income into the life expectancy. And that's the crores of rupees that you can save just by doing this treatment on time. I'd like to thank everyone involved in this, especially KSOS and Anubhav for this opportunity, Dr. Mahesh sir, my own founder, my colleagues Snehal and Sushma, and of course all the babies over these 18-20 years who have put in the faith into our system. Thank you so much.
Thank you, sir. Thank you, Anand sir. Anyone has any question to ask, sir? It's a great talk, sir. Really enlightening. Always, it's an honor to listen to your talks. Really a big honor. So next I'll invite, thank you sir, next I'll invite Dr. Divya Balakrishnan.
Can I have a question, please?
Pardon?
Can I have a question?
Yeah, please.
Sir, what percentage of babies with PAR, peripheral avascular retina, you treat? You treat all babies at 60 weeks or?
Yes, by definition, PAR 2 disc diameters or more, as Anubhav said. The current guidelines that will come out of the Indian ROP Society is to wait at least to about 48 to 52 weeks. But if you are in a scenario where you can do these treatments under general anesthesia, you can wait up to 55 weeks, which is recommended by the NNF 2020 guidelines. After that, there are two disadvantages. Not the fact that the baby is big and difficult to treat, but the retina starts thinning out. Physiologically speaking, fovea develops by the 44th, 48th week. And for normal fovealization, you should have normal peripheral retinal vascularization. So if you are not providing peripheral vascularization by that time, waiting for 60, 70, 80 weeks is no use, because then you are only treating dead retina. But if you are able to treat with 70 milliwatts, 80 milliwatts of power with, not that intensive burns that we do for type 1 ROP, but just like a PAR, like an FEVR pattern, then you can actually promote vessels into that area at that correct time. Doing it like he showed, late recurrences have been reported and I've seen children who come to me as teenagers, who come from the pediatric ophthalmology department as myopes. And when you do an angio on them, they have active new vessels. And they've been injected 12 years back. So it's a very scary scenario. In the words of Michael Treacy, if you give anti-VEGF to ROP, you're converting it into a phenotype like FEVR. So the short answer to the question is yes, PAR should be treated. When you treat would depend on your scenario, your comfort of lasering a baby under topical anesthesia up to 4 or 5 kgs, or whether you're working in an institute that has pediatric anesthetists, then you can push it a little longer. So wait for the blood vessels to reach zone 2, and then after that you can treat. If there's a recurrence, of course, you'll treat earlier. And that's the advantage of using a bevacizumab over a ranibizumab, where you get at least 12 to 16 weeks after injection before you can encounter the PAR.
Okay, thank you.
What model do you think will be feasible?
Sir, do work.
Like Anubhav is screening around 17 hospitals.
Yes.
So like that, So even in government hospitals, there is
There
what
is
sort
work,
of
but
model
that
use?
coordination is not happening.
Yeah.
I realized that when we were working with the Kerala government in 2018, that they all have excellent pockets in the government and private, but they were not working together. There is some, I mean, for the lack of a better word, some trust issues between the two. But I think this happens in every state, that the government is not allowed to send a baby to a private hospital if they have their own facility. But with the advent of public-private partnerships, with the mandate now from a Supreme Court that every system has to have a compulsory ROP program, and our, sir, that in 2015, that court case that happened in a tertiary care government institution in Chennai.
Yes.
After that, I think scenario has changed. My strong advice to you all, in some places, for example, this is being done in Madhya Pradesh, where the state ophthalmic society is taking the leadership. So they are making a representation. That's not happening in UP. In UP, we are forming a Section 8 company. But in MPOS, they are actually forming, as a state, the president and secretary are going and meeting the NHM and saying this is what we want to do. So these are different, if you all have classmates, batchmates who are IAS officers and who are in the healthcare, which usually I think ends up happening, this is a great starting point. The Karnataka model started simply because we had one IAS officer who was a woman who was completely convinced it can work, and she made it work. So I think it just needs that push.
Thank you, sir. And just one point to add to your question to peripheral avascular retina. In my experience in Kerala, what I feel is neonatologists are not very keen to give anesthesia to all these sick premature babies. So by that time, you can hold the baby, and if you still are seeing avascular retina, whether it is having ridge or not, if the baby is more than 40 weeks or crossing 40 weeks, laser it off.
Correct.
Don't
So
wait.
I think with your comfort of doing topical lasers, 4.5, 5 kgs is not difficult if you have a good assistant holding. And that is typically 44 to 48 weeks. If you can cross 48, usually you have, so in fact there is a great paper from Tapas's group which shows what is a vascular arrest. 2 consecutive visits about 2 weeks apart where the vessels have not grown at all, then you can concur that this is not going to grow anymore, and that's a great time to intervene.
Thank you, sir. Over to you, Dr. Divya Balakrishnan. Madam is senior consultant in LF. Over to you, ma'am, for surgical options.
Thank you, Anubhav and KSOS for giving me this opportunity. And please. So we don't want any babies to go to this stage actually. So whatever the talk which was given before, it should happen, and this should not happen. But despite all those efforts, sometimes babies do end up in this stage. So when it happens, so when do we intervene surgically? So the indications is like when there is a stage 4A, and if it is like 1 or 2 clock hours, still maybe you can try little laser, little posterior, and then see sometimes it regresses. But when it is more than 2-3 clock hours, then you have to keep really a close watch, and maybe we will have to intervene early. And then stage 5, which we don't want to see at all. And in some babies, unfortunately, when they present this late, then still we can do surgery. And at least in those cases, actually, you don't expect that babies to see like a normal one. But at least some mobile vision, or at least if they can recognize whether it is daylight or night, or read things or see things very close. And when there is a vitreous hemorrhage, this can happen even during the normal, sometimes it could be, it may not be even ROP also, when there is a coexisting systemic factors and or associated with ROP. Sometimes post laser, even late also, you come across some combined retinal detachment, because if your breaks are really very intense, so you have to be very careful. Sometimes you see these kind of even in the late presentations also. So before intervening, especially when it goes to stage 5, you do an ultrasound basically to rule out any other underlying pathologies. Second thing is to see what is the shape of the funnel, whether it is posteriorly closed or open, which helps to plan the prognosis and also your surgical interventions. And see, surgery in ROP, because you know all these babies are preterm and they have multiple systemic issues sometimes. So very important to actually do a proper systemic evaluation, including their systemic parameters like hemoglobin, the platelet count, if there are any other associated congenital diseases. And you need to have a dialogue with the anesthetist and the neonatologist. You may have to shift the baby immediately after surgery to an NICU setup. So, and you should inform the parents, like in case of any anticipated untoward event, then the baby need to be under follow-up, and all these things with counseling and a coordination between anesthetists, neonatologists and parents is very important before taking up any of these babies for surgery. and what do you do or in a surgery, or how do you plan it actually. So the aim of the surgery is, especially in stage 4 and 4B, reattach the retina, and to some extent it helps in the regression of the vascular activity. So what are the options? So you have an options of a scleral buckle and a vitrectomy. Scleral buckle, especially you can even try segmental buckle, that help to reduce the post-op myopia in some cases, and then belt buckle in some cases. Vitrectomy especially, it can be either a lens sparing or sometimes you have to manage it with a lensectomy. So how do you decide between these options? So it depends upon the zone of the disease, the stage of the disease, what is the nature of the vitreoretinal traction, the extent and the type of the retinal detachment, and whether the disease is still active or not. So if the disease is still active, especially when there is an active neovascularization of iris, then you may have to do a pre-op anti-VEGF 1 or 2 days before and then take up the child for a vitrectomy in those cases. So how do you decide between vitrectomy and the buccal surgery? So if it is a posterior disease, zone 1, then you will have to go for a vitrectomy. If it is zone 2 or zone 3, and a stage 4A where the traction is in the periphery, where it can be supported by the buckle and there is not much of a posterior traction, then you tend to do only a scleral buckle or a belt buckle procedure. Where there is a stage 4B and where the macula is off, then you will have to combine with a vitrectomy and a belt buckle. Stage 5, obviously you will have to go for a vitrectomy, and in most of these cases you will have to do a lensectomy also. So the basic principle you have to keep in mind is that when the traction is in the periphery and it is anterior, then you can go for a buccal surgery. If there is a posterior membrane and the posterior zone disease, then you will have to go for a vitrectomy. So what do you do in a vitrectomy, or how this traction happens? The tractional forces are, one is anterior to posterior, then circumferential and tangential tractions. So circumferential, you can see you might see that along the arcades, the superior and inferior arcade are getting connected temporally. That means like there is a ridge to ridge traction. That is what you call a circumferential traction. Anteroposterior, you see that posterior from the disc, the retina get lifted up anteriorly towards the lens. So in some babies with a delayed presentation, you might see with just beneath the lens, you can see the retina and the fibrous stalk coming up. So that is the anteroposterior traction. And then in the tangential, the entire thing would be pulled towards the disc. So what do you do in a scleral buckle? You actually change the vector force so that the periphery doesn't get dragged to the anterior. So that is what you do by doing a scleral buckle. Sometimes you can do a segmental buckle if the traction is limited to 1 or 2 clock hours. And vitrectomy, actually you are releasing those vitreoretinal traction, the traction force is removed, and along with that you remove the angiogenic factors. But it is a little difficult in these eyes because the anatomy is little different. There is no well developed pars plana in these patients, so you are actually entering through the pars plicator region. So you have to keep these things in mind when you operate, and you have to measure your sclerotomy distance accordingly depending upon the age of the baby. And so the main aim of the surgery is to attach the retina, because it has shown that eyes with a detached retina had very poor anatomical outcome and functional outcome, and anatomical reattachment is very important for preventing the future complications and for a better visual outcome. So this is one video which shows, you can see that there is a superior and inferior arcade which is lifted up temporal, there is a traction. So you release those traction, and here you can see between the disc and the peripheral ridge there is a traction, so you release that one. And the second one would be anterior to the ridge and between the ora serrata. So the aim of surgery is not to settle the retina intra-op, but to release the traction with the minimal dissection and leave it. So it will take time for this retinal folds to come back to normal, to reattach. In stage 5, it is a very difficult thing, and you don't want any babies to go to this stage. So basically the aim of surgery is to release these traction membranes, remove these membranes. So you will have to do a lensectomy in these cases, and you just let the retina settle by itself. It will take few weeks and months for it to go back. You don't anticipate these patients to get very good vision, but at least a mobile vision. So that is what the aim of surgery in this stage 5, and the functional outcomes are very less in these cases. So as I mentioned, the aim is to prevent further progression and to achieve maximum what is possible for this. And it doesn't end with the surgery, but you need to follow up these babies for refractive error, refractive corrections, intraocular pressure monitoring, and proper visual rehabilitation. So your job is done only when you do all these things. And thank you.
Thank you, madam. Yes, what madam told in the last, just doing surgery and settling the retina is not enough. In these babies, especially, you have to do post-op management in terms of visual rehabilitation, which is very important for long-term vision survival of these babies. So, any questions? Next will be our Mahesh sir, our president, and he is very expert in medico-legal aspects. Sir, over to you please on medico-legal aspects in ROP.
This post-surgery also, long-term, as you said, the long-term management. I had one buckle, one eye already gone, other eye buckle I did in 15 years back. And then cataract came, cataract surgery done, then cataract that opacified, YAG laser was not working, then IOL got subluxated. This continuously, it's a huge process going on. Okay, thank you Anubhav for giving me this talk. Me and Anand had been doing some medico-legal talk sessions in AOS. We are having one on endophthalmitis next year in Jaipur. So that we are planning, a drama we are planning. So I'm talking about why is ROP special in litigation? One, it's a preventable blindness. Once the child becomes blind, nothing else in the life can reverse anything. That initial stage, that window period is gone and nothing can be. So it will affect the whole life of the individual. The individual will be otherwise normal, only eye will be gone. And the compensation can be very, very high. And the person can sue you after 21 years. You might have forgotten or you might have stopped practice also. That time it will come. So these are some of the special scenario in ROP. Most of the litigations are against neonatologists who has not screened the ROP or they have not advised follow-up for screening or not documented for follow-up. And there are a couple of cases where ophthalmologist was found negligent for not for documenting even dilatation and what indirect ophthalmoscopy, whatever, and proper follow-up, it was not documented. So we have a lot of cases which taught us what to do, what not to do in ROP. The first case that Anand was mentioning was Krishna Kumar versus State of Tamil Nadu in 2015. This happened in 1995 when there was no proper guidelines also. Still, this case was lost and the compensation was 1.38 crores, one of the highest in Indian ophthalmology history. So basically, child was not screened properly, was not screened at all, I think. And later, there are a few cases which has come across the country, like Maharaja Agrasen Hospital versus Master Rishabh Sharma. Here also, it was not the hospital's failure to screen the ROP was the main problem, and 76 lakhs was given. So this point, I don't know why we are not able to highlight to the neonatologist and pediatricians. Whenever we, Anubhav had been trying to collaborate with the IAP and neonatal forum, their response is very, very, they don't know. Once one case comes in Kerala, then they will all wake up, I think. They are not very bothered about all these things. This is an article by Anand only, Improving Retinopathy, Medical Legal Perspective. He has published, and I think only one case had gone against ophthalmologist, where they have not documented what drops was used for dilatation, and all these things are not documented. So this is important. The documentation is extremely important. So basically, even if the patient or the child becomes blind due to your timely treatment, it is not going to be a problem. But if you don't screen and then the child becomes blind, it is against standard of care. So standard of care is timely retinal screening, latest guidelines to be followed, like now less than 2000 and how many weeks, Anubhav? 34 weeks and less than 2000, no? Yeah, 2000 grams, yeah. That has to be very clearly written down, and every neonatologist should know. Documentation, whenever you go to a hospital, you screen it and write some lines in the file. Be very careful what all you did, dilated fundus examination using ROP drops, then indirect ophthalmoscopy, this stage. At least don't write within normal limit, WNL and sign and come. So this document is going to be very important. And I think ideally you should keep one copy of the records in our hospital where we are going to. So poor outcome is not negligence, that is for sure, because in spite of all the surgery, many of our patients don't do well. Now coming back to, I thought I will put one more instance. We are usually going to the ROP neonatology unit and then screening. There could be other complications. Giridhar sir is here. Yeah. We had one cardiac arrest during LAO some 24 years back, which we in our hospital. So with difficulty we resuscitated and the child escaped. After that we are not doing any LAO and examination we will do LAO in our hospital. So we are doing in NICU only. That is another important thing. Don't do in a setup where there is no anesthetist, or suddenly if the child goes into cardiac arrest, we are all we are as good as a layman. So that is the thing. Number two, there was a scenario last month. We had one child coming from an NICU unit from elsewhere and wanted to give intravital injection. The patient, the child was taken, thought we will do under local and topical drops, and then the child was taken to the operation theatre complex where the mother was feeding the baby and handed over to the sister. Then sister saw that the child was not responding. Actually the mother had fed the baby and it had aspirated. So just imagine that baby was taken to the theatre, and after that we found that it was, child died in the, before it was taken to the theatre for giving injection. Luckily our anesthetist aspirated the milk and it was taken in a video, and immediately patient was packed off. So within a 5-minute delay we escaped actually. So this two incidents I wanted to tell, because now whenever you're operating these cases under general anesthesia is also a challenge. Many of them have problems, other problems. Like this case, in spite of having a very good workup in Shankar Nethralaya, the court found negligence, and the way they analyzed the whole scenario, improper atropine timings, choline use, exacerbating bradycardia. So they have gone through the file extremely threadbare. They have dissected and they found that they were negligent. So this is, then I told our story. Better to do laser injection in NICU only. Usually criminal proceedings may not come, but if there is a death in your hospital, it is going to be a problem. In there are judgments, the legal guidelines by Government of Kerala, High Court of Kerala. If there is a death or some major problem, they have to constitute an expert panel, and with that only they can charge a criminal case, FIR. So that is, guidelines are there in Kerala. So, and one more last thing is consent. Who will give consent for a child? Naturally, it's the parents, father and mother should be given consent. So we have, this book is released yesterday, everyone will get this book. There are laser consent and Avastin and anti-VEGF consent is there in that. So limitation period already explained. You have to keep the file for 21 years at least. So whatever you do, so that is the thing. Compensation will be very high, the reason I explained. But the bad outcome is not a fault of the doctor. So that is, and there could be a difference in opinion between Divya and Anubhav. Anubhav may say I will give laser, Divya may say I will give injection and followed by laser. Just document it properly. That is not a negligence in fact. So difference of opinion is not a, so it's a special scenario, and the litigations in ROP are not many, and not against us mostly, but it is a big burden to our. That's all. Thank you.
Thank you, sir. Thank you for enlightening us. One thing I want to just highlight, that we are all afraid of medical implications. If you are seeing ROP and you are seeing any suspicious stage, if you are referring patient 1, if you are giving some kind of treatment, even if you are giving scatter laser burns, you have done something. You are not being charged or liable for that compensation. Only thing, if you are not efficient enough to give treatment, give some amount of treatment, immediately refer. So keep your close friend who is doing ROP treatment in loop, and if you are having any doubts, either call him or send him the baby immediately. Delaying the baby, not finding the extreme stage on time, and unnecessary waiting for the treatment like 48 hours, 72 hours, 1 week will be a serious consequence. So don't delay in ROP. Either give some treatment, and injection nowadays everyone is giving. So giving injection is not a big deal. Anyone can give, just a little difference in technique, and you can just survive yourself and can survive the baby also.
Mistakes that we do is we don't document. When we go to NICU, in their file we are not documenting and we are not keeping a copy with us. We will just write within normal limit or something like that. So that is some loophole.
And please document with the flow chart also that this much of vascularization happened, just writing with a normal limit, zone 3.
Dilated fundus examination using indirect ophthalmoscopy. A photograph.
Yeah, but then not all places, not peripheral doctors, small doctors might not have. So at least document with your flow chart, with your diagrams on the piece of paper. Don't just write within normal limit, zone 3 avascular, zone 3 stage 1.
One of the judgments is coming, no, the photograph not been documented.
Yeah, the problem is, sir, in a small place, that is why, that is Anand's project of having this camera in every periphery and taking photos and documenting. That is also, if that itself will be enough, that's.
And if
there
baby
is
is
no
not
forest camera or any camera, then you have to properly document it and keep a copy with you. So that is.
Yeah, and one more last point, if the baby is not dilating, what madam just told, just to check 2 things. Either they have not been dilated well with the drops, or they are having envy eyes. So don't just get panic that baby is not dilating, baby has AROP or zone 1 ROP. Just see carefully anterior segment with your 20D or 28D, and with the indirect it is possible to see easily. You don't need to have slit lamp for that. Just see carefully, and if it is not having lot of envy eyes, which might have ectropy and uvea also, then just dilate once more, wait for 30 minutes, and then they take the decision.
I think the message should be that it's not to scare anyone who's doing an ROP, because you are doing a service and preventing blindness. I mean, like for so many years of life actually. So its only thing is that you need to be meticulous, just follow the guidelines, when to screen and when to refer. Whenever there is a doubt, there are many people around whom you can take help from. So don't run away from whatever you are doing, because that's a great work which many of us are not, I mean many are not able to provide.
We need more people to screen in the
Yes,
state,
yes.
that is for sure. Properly document, that is only term.
Thank you, sir. Thank you. We'll close this session with this, and I request MG sir to give memento to Anand sir. Sir, Dr. Divya, can all of us can come on the stage once, please.